Go ahead.
All right. Good morning, everybody. Thank you for being with us on this lovely morning on a Friday in New York. So we have the pleasure of having with us Dr. Vic Tapson, who is one of my favorite speakers and also is a professor of medicine, pulmonary critical care medicine at Cedars-Sinai, as well as is the vice president of medical affairs of Inari Medical. He has done majority of his training at Boston and has been in many premier elite academic programs, which do include Duke Medical School as well. So we have the pleasure of having him here with us, and he will be talking about the management of acute venous thromboembolism and pulmonary embolism. So please take it from here, Dr. Tapson.
Thanks, Asma. It's really nice to be here, and we'll make sure we have some time for comments or Q&A at the end. So this first slide just kind of represents where we're headed. So to maybe some new beginnings, sunrise, and here's some disclosures here. Asma mentioned some of these already. I've been involved with pulmonary embolism for a long time. So I saw my first case in about in the early 1980s when I was an intern. And I remember this patient because she'd come in the ED. She was 8 months pregnant, and she was sent home. She was told that her tachycardia and her dyspnea were due to anxiety because she was pregnant. And she was sent back to the ED. I saw her the second time as she was sitting in the ED, and she coded, and we couldn't get her back. And I went to her autopsy, and she had extensive pulmonary embolism. Really stuck in my mind. And I got started doing research in the PE world in the early 90s. It was a clot like this that was taken out of her, big clot going from the IVC or the iliofemorals all the way down past the trifurcation there. And as you guys well know, this is a big problem in the U.S. and around the world. As we go to about 8 billion people in the world, we probably see a death from PE somewhere around the world about every 12 seconds. So I know you guys are aware this is a problem. And some folks, including some of my reliable colleagues in Northwestern, believe that the death rate from PE is actually increasing over the last decade. Are we seeing more sick people, admitting more sick people, doing more chemo, advanced therapy for cancers, et cetera? Not sure. Some studies suggest it's leveled off, but bottom line, it's still a problem. And there was a report a couple of months ago suggesting of more than 7 million incorrect diagnoses made in EDs every year, that among the top 5 was DVT and PE. So again, we got to think about this. We got to teach our medical students, interns, residents, trainees that this is a problem and got to recognize it. All these people died from PE. I like to show some kind of a slide like this once in a while. I won't go through all of them. CJ Fuller was a running back for Clemson, 22 years old a few years ago, had knee surgery, died a week later from PE. Emily Mitchell, an influencer, pregnant, 36 years old, died of a PE, lost her child as well. Michael Johns, American Idol singer, found in his friend's apartment dead from PE. Heavy D, that was 10 years ago, died from PE in Los Angeles. Jordan Feldstein, Jonah Hill's brother, 40 years old, manager of Maroon 5, died of PE a few years ago, and so on. And you get the idea. So, and of course, it's not just famous people. So we got to make the diagnosis. I think that's really important. This patient, sudden onset dyspnea, pleuritic chest pain, no cough, no fever, tachycardic, no white count. So no cough, no fever, no white count, was diagnosed with pneumonia based on that kind of right lung infiltrate. You can't be admitted to the hospital with pneumonia without having a cough, unless you're out of it or intubated. So if you're sick enough to come in the hospital with pneumonia, you're not often just short of breath, but you have a cough. And this patient also had pleuritic chest pain. And so someone thought, well, maybe we should think this a little further after a couple of days, and got a CT scan. And sure enough, there was acute PE in the right lower lobe and a Hampton's hump there. Unfortunately, this patient was saved. So got to make the diagnosis. And we got to anticoagulate. That's one of the bigger messages here. Anticoagulation saves lives. Sean Smith's study showed if you come in the ED and you're in the ED more than 24 hours without a therapeutic PTT, you're more likely to die from PE. So we got to get people on anticoagulation, see if it's safe, get them on quickly. If you suspect PE and the bleeding risk is low, but your suspicion for PE is high, it's reasonable to go ahead and start anticoagulation even before the diagnosis. We often use low molecular heparin nowadays. It's faster. You get someone therapeutic in 3 to 4 hours, you're good for 12 hours. So anticoagulation is critical. I've felt we need to be more aggressive for PE for a long time. With prophylaxis, I think we finally got that sorted out. We have electronic clinical quality measures we use now for patients admitted, and we do a better job with that. I think we still have a ways to go with diagnosis and therapy. So I wrote this paper 15 years ago. I still believe this. And even longer ago, I was doing work in the PE world. I'm not going to spend time talking about my work or manuscripts, but again, I thought we needed to do something with pulmonary embolism 30 years ago. And we were doing studies in animals, and then finally in people, putting catheters in people and trying to figure out ways to break up clot and treat patients more aggressively. This was a PA-gram we did back in the 90s. Actually, that's an IVUS catheter going there into the pulmonary artery. This was a very sick patient at the bedside. Our portable VQ scanner was down, and I went down to the CCO and said, "I heard you got this thing called an IVUS. You can do you can look into vessels with." So we went into the IJ, and then had some difficulty with that. Went on the femoral. Bottom line is we were able to ultimately make a diagnosis of acute PE. So this patient came in, 60 years old, unprovoked PE, dyspnea with 10 to 20 feet ambulation. So he's pretty short of breath. Very noticeably nervous and fidgety, and even said this, "I think I'm going to die," kind of a sentence we hear sometimes in people who are sick with pulmonary embolism, other disease states associated with pheochromocytoma, but certain disease states, people come in, they get this feeling of impending doom. Tachycardic, tachypnic, blood pressure soft, don't know his baseline. RV was big, dilated, severe dysfunction. TAPSI, tricuspid annular plane systolic excursion, was low, very low at 1.2, meaning the RV is not moving very well. Trope very elevated. So this is an intermediate high risk PE, right? We call them submassive nowadays. We divide into intermediate risk, high, intermediate, low risk. Intermediate high means his RV is abnormal, his trope's abnormal. Intermediate low would be one of the others abnormal. So think for a second what you might do with this patient. Look at that clot burden. There's also got a pleural effusion there, which might affect his reserve, but he's got very extensive bilateral acute PE. Hard to calculate an obstruction score solely based on this, but note that his SAT was low too, 92% on room air. So think about how you might handle this. Many people might say, well, let's just anticoagulate and watch him. And that's where I'm kind of troubled. So this patient's clot burden easily more than 50%, probably more than 70%. I think clot burden is important. We don't often think about that. So we'll talk about a little bit of data here. Also central clot, which in one Italian study was associated with an odds ratio of more than 8 for PE-related death. So this impending doom thing, we've talked about this years ago. It should signal something bad. It may not be PE, but some have felt it's more associated with PE than other cardiopulmonary diagnoses. We might hear it more with PE than we do with MI, for example. So there's the patient's RV-LV ratio. We have this measured. We have artificial intelligence to do. We use the ADOC system, and that immediately sends, as soon as the computer reads a CT, we get the images of the PE we can scroll through on our phone, and also the RV-LV ratio measured. And again, an RV-LV ratio greater than 1.5 by our friends in the Netherlands was associated with almost a 1 in 5 death rate from acute PE. So again, I don't have the echo for this patient. He had a bedside echo that showed poor RV function. So what else? Look at the contrast. There's other things to look at in the CT beside the clot. Significant contrast reflux way out to the distal hepatic veins. This is grade 6 contrast reflux. Nice study by some colleagues in Israel, published years ago, 2008. If you have grade 4 to 6 reflux, proximal or out to distal hepatic veins in acute PE, 20% mortality at 7 days. So again, this patient has a number of features suggesting an increased risk for death. But again, we don't have a randomized trial proving that patients with intermediate risk PE can benefit from being more aggressive. I think they can. I think their data, but we'll come back to that. This patient was discharged on day 4, heart rate 96 per minute, O2 sat 93% on room air rest. I probably would have walked him, see if he needed O2 to go home. I'm not sure I would have sent this patient home yet, but we did an M&M on this patient. I never saw the patient live. Went home and coded on the commode. 5 days later, at autopsy, had extensive PE. So again, I think this patient had a number of features, a number of factors suggesting increased mortality. I've listed a number of things here that am associated with increased mortality in PE. Hypotension, we kind of all agree with. Hypotension defines high risk or massive PE, but abnormal RV function size, like I mentioned. TAPSI less than 1.6, we showed was associated with increased death rate in PE. I've never made a decision about how aggressive to be with PE based on TAPSI, but we have an MD calc that might be on it. Elevated trope, intermediate PE classification, SPESI greater than 0. Any one of those points now, we don't use PESI so much now. I tend to use SPESI. It's been shown to be just as predictive as PESI. 6 things, any one of them gives you an all-cause mortality that's tenfold increased. And so I'll talk about a few other things here on the list. Even elevated D-dimer. Look at D-dimer. 3 studies now. We use D-dimer to rule out VTE, right? If you've got a low to intermediate suspicion of PE and your D-dimer is negative, you're off the hook. If your D-dimer is elevated, you go ahead and work the patient up. Or if the suspicion is high, the D-dimer probably should be skipped. Just go ahead and get imaging, right? So a number of things that have proven to be associated with increased mortality in PE. But again, no randomized trials. But again, does that mean we shouldn't consider individualizing these patients and consider being aggressive in PE? And I believe we should. It's kind of like the parachute study, right? We don't have a study that shows that parachutes work. We don't have a randomized trial. All we've got is observational data. That wouldn't be level 1A data. We've got observational data that parachutes work. Again, I think there's some areas in medicine where we may not need, or at least we may need to act before we have randomized trials. So I want to talk a little bit about this for a few minutes. This is a study our friend Cecilia Beccattini published over in Italy. Almost 1,000 patients divided into this European Society of Cardiology, ESC model, high risk systolic blood pressure less than 90 for more than 15 minutes, intermediate highs, we mentioned RV and abnormal trope, intermediate low, either abnormal RV or abnormal trope, and low risk. And she divided them into 2 groups, either hemodynamically unstable, which is the high risk patients, or hemodynamically stable, which I put in quotes because, again, I don't think we should really be considering everything below the red line as stable or as the same. And she went on to look at PE-related mortality in these patients by the 30-day mark. And in fact, if you had intermediate high-risk PE, your mortality rate was 10 times higher due to PE than if you're low risk. If you're intermediate low risk, your mortality 4 times higher than if you're low risk. So again, to me, that means that intermediate risk PE patients, of course, need anticoagulation and a conversation with potential for intervention. Your PE response team, pulmonary critical care seeing these folks, cardiology seeing them, somebody expert seeing these patients and making decisions. So intermediate high risk PE has had a mortality in studies ranging from about 5% to as high as 15%. So we've got to take this disease state seriously, and these patients can change quickly. Heart rate. Heart rate's been predictive of mortality in PE, and I think I've used heart rate more than any other parameter to make decisions about PE. Of course, blood pressure if someone's hypotensive, but non-hypotensive PE patients, we showed significant tachycardia, of course, indicates the RV is having trouble compensating. If it can't pump well, it speeds up, right? And so increasing heart rate, increasing mortality. Our friends in Germany showed if your heart rate's greater than 100 per minute, your chances of dying from PE were 4 times higher than if your heart rate's less than 100 per minute. P-value is significant. Doesn't mean everyone with a heart rate of 101 needs to be aggressively treated, but I believe it does mean they need a conversation and consideration. And as we develop safer ways to treat acute PE, it makes more sense to be more aggressive, in my view. So clot burden, I alluded to clot burden earlier. There's 3 studies that were looked at together by Dr. Meinl, and these 3 studies, Dr. Wu, Vandermeer, and Chaucer-Wanakit, all looked at different obstruction indices, 40% in one study, 60% in one, and 70% in one. So they weren't all the same. But the bottom line, they determined that in each of these studies, that was a significant obstruction index, and they found a predictive value of a significant obstruction index found for PE-related mortality. Pooled odds ratio for PE-related mortality, 17.6. Broad confidence intervals, the point estimates are all on the right side. And again, while the confidence may be broad, the first one in the Wu study, 4.4 to 440. I think this means clot burden matters. We know it matters. If you have clot obstructing every vessel in your lung, you're going to die, or you're going to code. So clot burden clearly matters. Some of the studies that haven't shown that clot burden matters, to me, are troublesome because they often don't show enough patients with big clot burdens. If you do a study of 200 patients and only 2 have an extensive clot burden, you're probably not going to show that clot burden matters. You need to look at enough patients that have extensive clot burden. So anytime I see a big clot burden, it makes me do a double take. It also reminds me of patients who may die solely from their clot burden and not from even recurrent clot coming up from the legs. I saw a patient, it's been many months ago now, but it was called on a Friday night by Sam Trabati, our ED doc. And he said, Vic, I got a patient, I'm sure she has PE. We're sending her to the scanner now. It's Friday, I'd let you know. It's kind of late. It was 6:30 or so on a Friday afternoon. So I went to the scanner to see her, and she just finished her CT, was laying on her back on the CT scan, looked pretty comfortable, extensive clot burden, and the techs rolled her over onto the gurney and she coded. Her legs had already been scanned, they were negative. So what happened to her? Did she have a clot high up in her IVC? Maybe. Or did she just have this big clot burden that was not quite occlusive? She turned and moved and her clot moved and it became totally occlusive. Clot shift, I call it. Hard to prove it happens. Bottom line is, I think clot burden matters and big clot should be discussed. Here's a little clot. This patient has a small PE, presented with a little bit of shortness of breath. Fortunately, somebody felt this was probably PE and made the diagnosis. And this is a good patient to anticoagulate and send home, right? Trope was negative, RV was normal. Legs weren't scanned. I always think it's a good idea to scan everybody's legs before they go home and also look at their RV. Even if a clot, we know in a PE this size, RV is not going to be big and abnormal. But in 5 to 10% of patients, we see clot in transit. Clot in transit has been associated with increased mortality in PE. So this patient went home and died, had an autopsy, had a huge saddle embolus. And why did he die? Well, I think he died because he likely had a big clot remaining in his leg. And this is an MR venogram that was done, patient, and this kind of, to me, tells the tale. I think remaining DVT matters. The 3 studies on the left, I won't go through in detail in interest of time today, folks, but Dr. Manus' study in the Blue Journal, David published a paper showing if you have acute PE and proximal DVT remaining in your leg, your your hazard ratio for death was 4.2. Beccattini confirmed this in a meta-analysis. Nishiwaki also confirmed this in their study. So bottom line is, if you have PE and clot remaining in your leg, you're more likely to die. Do we do anything different about it? No, there's no guideline to say we should. There's no randomized study that proves being more aggressive makes sense in patients with acute PE and clot remaining in the leg, but certainly it's very logical that these patients would have a higher chance of dying if there's something remaining in the leg that might still break off. Often anticoagulation gets people taken care of, clot organizes, sticks to the wall, and slowly breaks down over time, but sometimes it doesn't. So what do we do with these patients? Well, they should be discussed nowadays. Should we treat them more aggressively? I think they need to be individualized. And that reminds me of a rocket taking off. There's a big, huge iliofemoral clot there. Lactate. Lactate's a marker for bad disease in every disease that's ever been studied in, right? This happened to be an editorial that Nicholas Menevo wrote involving pulmonary embolism. But if you study pancreatic cancer, several cancers, elderly patients admitted to the ICU, nosocomial pneumonia, any of these situations where your lactate's up, you're more likely to die than if your lactate's not up. And PE is no exception. So Simone Vanni and David Jimenez and others did this study, and they looked at almost 500 patients who were normotensive with acute PE. 496 patients, normotensive, lactate negative, and lactate positive. And I think if you look on the left side there, primary endpoint was a composite of 4 things: 7-day PE-related death, shock, hypotension, mechanical ventilation, needing CPR, and then at the bottom, 30-day PE-related death, and so on. Look on the far right, every p-value was significant if your lactate's up, except mechanical ventilation. And as you know, we don't like to intubate PE patients. We don't like to give them that positive pressure that might make the RV buckle finally. We do it when we need to. Obviously, if someone's got to be intubated, you got to do it. But we try to get experienced intubators. often cardiac anesthesia to do it, carefully intubate them. But bottom line is lactate predicts death in acute PE. So while we can often make a decision about being aggressive in PE without a lactate, if you can't make the decision or you're arguing about it, get a lactate. It may tip the scales for you. Guidelines. Well, we could talk a long time about guidelines. I'm a big fan of guidelines in many ways. I was involved with the ACP guidelines. I published the ATS guidelines for diagnosing PE in 1998. I was involved with the World PE guidelines. Number of sets of guidelines that are used. In pulmonary critical care, we often use ACCP, and cardiology, AHA. There's other guidelines. ESC guidelines are really nice ones, the European PE guidelines. This is a simple guideline done by two interventionalists, PE interventionalists. When I say that, guys that have gone in and done aggressive therapy for acute PE, and two PE non-interventionalists, Greg Piazza and Neil Goldenberg. And they wrote this little algorithm back 7 years ago. Acute PE, stable, normal biomarkers in RV, anticoagulate. If you had elevated biomarkers, abnormal RV dysfunction, consider advanced therapy. Of course, you consider it with hemodynamic instability. They said consider advanced therapy, either systemic lysis or catheter-directed embolectomy, et cetera. If you've got if you're intermediate high risk, so consider it. And they even considered intermediate low risk because they said elevated biomarkers or abnormal RV. What does ESC say? And these intermediate risk PE patients, I think, are the ones we often discuss and sometimes can't agree on. And they make there's no 1A recommendation for anything. So we don't have a perfect recommendation here. But 1B recommendation, rescue thrombolytics is recommended for patients with hemodynamic deterioration on anticoagulation. And as an alternative, it says, to rescue therapy, surgical embolectomy, percutaneous catheter-directed treatment should be considered. So they're saying this is perfectly acceptable. It's a 2A instead of class 1 recommendation, but it's a recommendation nonetheless. And I believe these are some ways we can safely treat acute PE nowadays. But these guidelines want you to wait for deterioration. And again, I don't know that it's fair to wait for deterioration. You've got a patient with a big PE and parameters that are concerning, to say, well, I'm going to sit here, I'm going to wait, and I'll call another doctor and get them involved with your care if you crash here, if you get worse, if you deteriorate. It might be 3 a.m. when they're short-staffed, when they don't have the resources they need, when they're a little tired, but we'll get someone to come in and help you. And I never felt like that was a good idea. Again, doesn't mean every intermediate risk patient needs to be intervened on necessarily. Maybe the clot burden is not so big, trope's barely elevated, RV is almost normal, but abnormal. Maybe those patients you'd consider watching. But the bottom line is we got to think about these. What does ACCP say? ACCP also says if you're intermediate risk and you deteriorate after starting anticoagulation, but have yet to develop hypotension, acceptable bleed risk, we suggest systemic lytics over no such therapy. Now, that's a weak recommendation, low certainty evidence. That means we don't have to go that route. If we don't want to, we can consider doing something else. Again, I like the fact that at least they say you don't have to wait for hypotension, because so many of my colleagues feel like hypotension is what makes you allowed, so to speak, to be aggressive with acute PE. And that's not the case. It's deterioration. And what's the definition of that? It could be a number of things. If your heart rate goes from 90 to 110, you've deteriorated from PE. If you're sitting there still and you're not short of breath, and an hour later you're short of breath from your PE, that's deterioration. There's a number of things. Blood pressure drops from 120 systolic to 105 systolic. If you think that's from PE, that's deterioration. So again, you don't have to be hypotensive for guidelines to justify being more aggressive. And I don't think you even have to deteriorate. And I think we should keep in mind that recommendations by guidelines often become outdated, and ACCP is pretty conservative. They're pretty conservative guidelines. So is there a safer alternative than thrombolytics? Well, it's something I want to talk about too. I've been interested in this for 25 plus years. This is an intermediate risk PE. This PE sitting there looking at you. You know it's dangerous. And what do? Are you going to do something or you're not going to do something? And that's the decision. You cross your fingers and you hope nothing's going to happen, or you decide to get aggressive. And this is acute PE deteriorating. I like this little analogy. You know, you're waiting for something that you know is bad. And should you wait, or do you have a way you can address this without causing any safety problems? ASH, American Society of Hematology. These are good guidelines. My buddy Tom Mortell at Duke in hematology led these. These guidelines, Tom said, as other guidelines say, are not intended to serve or be construed as a standard of care. They're guidelines. And so clinicians make decisions based on the clinical presentation, their experience, standard of care there at their institution, consider patients' values, et cetera. If a patient has a very extensive clot burden, is tachycardic, for example, and you're concerned about them, but they haven't deteriorated, they're not hypotensive, and you say to that patient, look, we can get this clot out of you or do something, here's what our data show, or we can sit and wait and watch you. Patients may want to have some input, since we don't have a randomized trial. I always like to point out that even though I'm a fan of guidelines, they help guide us. That's what they do, they guide us, and they don't tell us what to do. Even our doctor lawyer friends say clinical practice guidelines are designed to improve care, not define the standard of care. And they never win in court. Those of you that do medical legal work, you've learned, and I've only done medical legal work in PE for the last 25 years. If someone dies of a PE, I've defended physicians. I've never testified against doctors. I have trouble doing that. I defend physicians because a lot of times there's nothing you could have done. There was no clear prophylactic recommendation for that patient, or that patient sat there maybe a little too long but died, but causation would say nothing could have been done differently. And the bottom line is courts, these doctor lawyers say courts should exclude practice guidelines from the evidence. Standard of care is what counts. And again, I don't like to talk about medical legal stuff, but we think about it sometimes. So keep in mind, I've never seen a case win based on guidelines. The decisions are made based on standard of care. What about thrombolysis? Well, I've been a big proponent of thrombolysis for a long time because that's all we had. Trying to break up clots, do the best we can with lytics, and we still need lytics sometimes. I think if someone crashes, you've got a high-risk PE, you can't move them, they're hypotensive, you're on 3 pressors, you turn them on their side and they desat to 60% on a non-rebreather, that's catastrophic PE. Those patients need ECMO or they need lytics. You know, Montefiore is a huge hospital. I'm sure you have ECMO there. And the decision has to be made. What do you do if you can't move the patient? Do ECMO or lytics? Or if you don't have either one, if there's contraindications to lytics and you don't have ECMO at your hospital, you either transfer them if you can, or if you have the means, you drag them to the cath lab, get them there as safely as you can, and do a catheter-directed procedure. So there's options. But the bottom line is we need thrombolysis in certain settings. But if we can avoid it, we'd like to avoid it. Because we know our ACCP guidelines told us 30 years ago that in MI, lytics appear to dissolve the coronary thrombus in most cases, but in VTE, especially PE, complete dissolution is the exception. And that's because we know that the longer that clot sits there, the more organized it gets, the more collagen it gets, the less likely it is to break up. So you may get the acute part, it may save a patient, you may cause a head bleed. Bottom line is, to me, these drugs have helped us in a lot of ways, but if we can move away from them, maybe we could. This patient underwent catheter-directed lytics for an acute iliofemoral DVT. I saw this patient, referred him to our interventionalists, and again, this was another weekend case. I think people kind of in a hurry want to throw a catheter in him, and they put a catheter in, catheter-directed lysis, got a total of 8 milligrams of TPA and bled in his head. Didn't die, but is dysarthric, hemiplegic, can't communicate. This is a successful executive. So if you don't have to give lytics, don't give lytics. If you have to, give lytics. This is splenic artery aneurysm. I still follow this patient, fortunately. Huge hemoperitoneum, hemoretroperitoneum. This is in one of our catheter-directed lytic studies. He bled and fortunately did okay. 10-unit bleed and survived. But bleeding is a concern, obviously. Anyway, new drugs. We've got some new drugs people have used. Tried different drugs, tried alpha-1 antiplasmin, that's been studied and now being studied in a prospective study by Guy Reed in Arizona. TAFI inhibitor study, we were publishing our TAFI data. It's been accepted for in the journal Thrombosis and Hemostasis. We did this study looking at this TAFI inhibitor, thinking this drug, this thrombin activatable fibrinolysis inhibitor, would lyse clots and maybe not have the same bleed rate as TPA, but it did. Vampire bat TPA has been tried. We thought that because of the excitotoxic injury that TPA causes, which is why we get more brain injury with TPA than certain other lytic agents, this drug didn't work. Desmodoplase, vampire bats, they bite your neck. They inject their TPA to thin your blood, and so they can suck it out easier. We thought, well, maybe this drug will be the one, but didn't pan out. So again, are we going to come up with a lytic agent that doesn't cause bleeding? I don't know. I'm not sure. But it's a ways off. CTEPH, you guys know about CTEPH. I've followed PE patients now since the early 90s. When I see some patient in the hospital back at Duke when I was just starting to do PE research, my colleagues would send all the patients my way because, Vic has a PE protocol. Let him see the patient. And I would see them and I would follow them. And every patient I saw, I've seen since, I give my cell number to. My patient called me last night. He just got back from Africa. He'd had PE before. He's on Xarelto. He's having some leg discomfort, both legs. I don't think it's DVT. He's going to get a D-dimer this morning. I like my patients letting me know what's going on. And I find it much easier than taking 10 calls at once on a Monday morning. I like him to call me. So my point is I follow these folks. I know what happens to them. I know the rate of CTEPH is probably what Vittorio Pengos determined in his study in 2004 in New England Journal. It's probably around 4%, something like that. But I think following these patients to me is very important. And I know what happens to them, and I know when intermediate risk patients go home and die. And the Spanish registry suggested that if you go home and die of PE, usually in the first 5 days, 75% of patients die in the first 12 days. A lot of times we send them out to the floor from the unit or home from the floor, and we don't know what happens to them if you don't follow them. You don't know if they got admitted, if the EMS was called, if they died at home. I always know because the family or the patient calls me and lets me know what happens. And I feel like based on this experience over almost 30 years now, that we underestimate the risk of death in intermediate risk PE because we often don't have full, complete prospective follow-up. And long-term problems occur as well. I'm going to mention just briefly this concept of RPVO, residual pulmonary vascular obstruction. Our European colleagues have done most of these studies. In the US, if someone has PE, we see them at 3 months or 6 months in clinic and follow-up. If they're still dyspneic, of course, we work them up. Is it CTEPH, RPVO? Is it residual pulmonary vascular obstruction? Or is it something else? Is it post-PE syndrome? And again, what this set of studies showed, if you have RPVO, look at that top line there, your mortality, your recurrent VTE rate, right heart failure and dyspnea, and CTEPH rates were all higher than if you had no RPVO. And of course, CTEPH rates are higher because you can't have CTEPH without having RPVO. So again, I think we should take this into account. Normally in the US, again, we don't repeat scans unless someone's symptomatic. We'll often repeat ultrasounds. I generally don't stop anticoagulation without making sure there isn't something going on in a patient's legs. If there's extensive, poor recanalization, chronic DVT, I don't like to stop anticoagulation. But with PE, the trend has not been necessarily to do this. So maybe a lower threshold to do a VQ scan, for example, at 3 to 6 months. If it's normal, you're off the hook. The patient doesn't have CTEPH or RPVO. But at least consider it, especially if there's any hint of symptoms. Can taking out large clot burdens up front improve long-term outcomes? Maybe. We don't have randomized trials proving that. It kind of makes some sense if you have CTEPH and a significant amount of patients with CTEPH have huge clots to begin with or extensive pulmonary embolism. So one risk factor for CTEPH is extensive PE at presentation, as is splenectomy, chronic inflammation, elevated factor VIII levels or antiphospholipid antibodies. These are risks for CTEPH. So it does make some sense that being more aggressive up front may be helpful. Oh, this is a patient of mine. This is Nellie. I saw her about 3 weeks ago in PE clinic, and she has trained many of the animals you've seen in Hollywood movies. Nellie, she's in her 70s now. She raised a cougar from a pup, just gave it away to a wildlife refuge in Texas. She raised that bear, honeycup, I forget what his name is, from a cub. Nellie will call me and she'll say, "Oh, Dr. Tapson, I'm training this leopard. He scratched all down my back. Do I stop my Xarelto?" And I'll have someone will send me a photo of it. And we'll make a decision about what to do. Or she'll say, I was feeding Honeycup and he fell over and knocked me against the wall and hit my head. Do I stop my Xarelto? I like being able to contact my patients and be in close touch. I like them to be able to call me. And if I can pick up an answer, I do it. And in 25 years, I've never considered this a problem. Well, there have been a few times, I guess, there have been a few too many calls from a patient, but bottom line is, I like to try to offer the best care I can. Devices to treat PE. So Laser Greenfield came up with the Greenfield filter, published his data. The first paper was 1973, but in 71, published a paper called Transvenous Pulmonary Embolectomy by Catheter Device, and studied this device, treated 2 patients successfully, had one that died earlier. But the bottom line was, Laser actually was interviewed in about 2011 and said, independent of my filter, he said, except for my filter, I thought that the catheter embolectomy was the best idea I ever had. And it kind of dropped off the map a little bit for a while. Now we've got different therapies for acute PE. Anticoagulation, I mentioned, this is critical. We got to get people anticoagulated. If they can't be anticoagulated, we put a filter in until they can. And of course, we try to get those filters out. Additional interventions, we've got systemic thrombolysis, which of course you're well aware of, catheter-directed lysis. Again, I mentioned the limitations with lysis. Sometimes we need it. I don't see any reason to do catheter-directed lysis anymore. It takes too long. It takes, at least 6 hours, 8 hours, 10 hours. Patients have to lie in the ICU with a catheter in them, and we can sometimes avoid them. There's the Penumbra Indigo system for suctioning clots out, the angiodynamic system for suctioning clots out, more used for right heart clot really than for acute PE, and the Inari Medical flow retriever system. And I've been involved with some of these different systems. I was one of the principal investigators for the flow retriever study, the FLAIR study, got the device through the FDA. I also worked on the Penumbra study, got that device through the FDA. I worked on the ECOS device, et cetera. So some of these different devices had some experience with. Flow retriever devices, FDA approved for PE and also for clot and transit in the right heart. So what about ultrasound facilitated catheter-based lysis? Again, I don't know there's any reason to do it anymore when you can do catheter-directed embolectomy and much quicker, and we've got safety data. So this study, the original study by Niels Kuker, 59 patients randomized, he improved RV-LV ratio at 24 hours with catheter-directed lysis more than you would with heparin. So randomized trial. And then the Seattle 2 study was done, Greg Piazza, 150 patients. We did the Optimize study. And these studies, we found improved RV-LV ratio. So no mortality data in these studies, but RV-LV. And the last 2 studies were single arm. Optimize was multiple arms because we looked at different doses, but we didn't have an anticoagulation arm. I really wanted an anticoagulation arm for this study, but it wasn't granted. What about other clot extraction devices? This was one of our first cases back in 2015 or 16, looking at large bore embolectomy. And we had this patient come in, terrible pulmonary fibrosis, got a lung transplant, and the right lung was transplanted. You can see the left lung, terrible UIP, IPF there. And look at the, you can see on the lung windows here, the big PE in the right lung, unilateral PE, terrible useless left lung. So with single lung PE, this patient is dying on pressors on a non-rebreather. And what do? Well, this is 2015 or 16. We said, well, I don't know, we hate to give her lytics here. She's only a couple weeks after a transplant, but we better do it. There's the soft tissue windows, big clot there. So we said, well, RV looks bad on echo. It's not pumping very well. I don't have the video here. We gave her 50 of IV TPA. And we watched her. And hour, 2 hours, 3 hours later, no improvement. What was the problem? She was febrile. She had a white count. Was she septic? Maybe we got the clot. Creatinine was up a little bit. We CT'd her again. No benefit from the TPA more than 3 hours later. Should have worked by now. Didn't. So what do we do? Well, we said, well, let's try this new device we've talked about. So we use this flow retriever clot extraction device that's now approved. And we've got data for it, got a lot of clot out, post flow retriever CT, markedly improved. This kind of got us excited about this, and we started doing cases with catheter-directed embolectomy. And during the pandemic, especially the Delta wave, we started doing cases in COVID patients. They'd come in, we had no ICU beds, and we found we could take these patients to the cath lab and often take them to the floor or step-down unit without having to go to the ICU. So that was a huge plus. Don't want to use an ICU bed if you don't need it. Don't want to give lytics if you don't have to. And then we've got some data and I'll just show you some data in catheter-directed embolectomy. Very quickly, the flash data. I'll show this data for FlowTriever because this device has by far more data than any other clot extraction device here. So again, 800 patients, less than 1% all-cause mortality at 30 days. And keep in mind, there were 50 sites around the country. This isn't one expert site doing this. 50 sites around the country involved these studies. And again, most patients didn't need overnight ICU stay. So again, I think making some inroads in the interventional world with PE makes us feel more comfortable. If you have less than 1% mortality, it makes you more comfortable being aggressive with a patient that might be intermediate risk. We don't have randomized trials, but we certainly see low mortality, and we know these intermediate risk patients are concerning. Again, 30-day visit, there were 6 deaths, but that's only 0.8% mortality. The other thing I thought was interesting in this registry was CTEF rate of only 1.2%. Look for CTEF, 1.2%, much lower than other studies show. Now, again, we don't have a comparator arm. We can't prove that being aggressive up front with acute PE reduces the CTEF rate. But this is certainly intriguing data, and I hope we get more in the future. And distal emboli are extracted well. There's a kind of a subacute clot that was pulled out. So segmental, subsegmental, lobar emboli extracted. Randomized trials done. This company I've done work with now, I work with now, Inari Medical, is doing randomized trials, not just registries, randomized trials. The Peerless study now has enrolled more than 300 patients. This is large bore embolectomy with FlowTriever versus catheter-directed lysis for intermediate high-risk PE. We'll see what it shows. I think it'll show that maybe we don't need to use lytics. The primary endpoint is being done by a win ratio, which I think is a very clever way to do this, a hierarchy of important endpoints. We'll see what happens here. Here's a patient that came in, extensive clot burden here, certainly more than 50% or 60% on the frontal views. We've got the axial views here too, extensive clot in the distal main PAs, tachycardic, RV looked bad, don't have the video here, but RV looked bad. Trope was normal. It's an intermediate low-risk patient. S-PESI greater than 0 based on heart rate there, extensive clot burden. I won't take the time to ask everybody what they do with this case, but this patient was symptomatic and not sure why the trope wasn't up. Usually a patient with a clot this big has an elevated trope. This patient didn't. And extensive clot burden was extracted, FlowTriever, PA pressure came down, heart rate came down on the table. So again, I think intermediate risk patients need to be discussed. And by the way, this patient had a cardiac index we didn't anticipate. Didn't anticipate kind of a shock level cardiac index of 1.85, but it went up right afterwards. Measure PA pressures and cardiac indices, and easily demonstrated that the pressure went up, that the index went up. I'm assuming this patient may have had an elevated lactate also, don't know. I want to finish with a few comments about high-risk PE. This is the study that gives us a level 1B recommendation for lytics in PE, done many years ago with streptokinase, a drug we don't use anymore really for PE. 8 patients randomized, 4 to streptokinase, 4 to heparin, and you can see all 4 patients randomized to heparin died within 3 hours. Catastrophic PE. Hard to do a study when people die within 3 hours and see what works. But that's all we've really got, except for meta-analytic data that's throwing things together. So what does ACCP say? They say if you've got PE and hypotension, if you don't have a high bleed risk, we suggest thrombolytics. They don't say we recommend thrombolytics. They suggest thrombolytics. Weak recommendation, low certainty evidence. That means you're not wedded to thrombolytics for high-risk PE. And because it's a weak recommendation with low, you take the situation. If you can do something else that might not offer the head bleed risk, maybe you consider doing it. The remarks made are studies of lytics have used different agents, varying doses. Due to lack of comparative data between these approaches, the panel does not endorse one agent or one dosing strategy. So there's a suggestion to give lytics, weak recommendation, give lytics over no lytics in high-risk PE, but no suggestion or recommendation on the agent, the dose, or the duration. So that certainly is a weak recommendation. We use 50 of IV TPA when we use it. If someone's coded, we'll often use 100. But I think moving away from lytics makes sense now that we have clot extraction safety data. So what kind of trial has been recommended? AHA made some recommendations about high-risk PE. As I kind of wrap up here, I'm going to point out the AHA had recommended, based on the fact that lytic studies and high-risk PE studies, randomized studies are hard to do. there's complication rates, there's crossover rate, when you bail someone out, how does that affect randomization? They've recommended non-randomized prospective studies with pre-specified performance goals, meaning let's see what the literature shows and then decide how to do a study, maybe not a randomized study. And so based on that recommendation, this big meta-analysis was done by Mitch Silver and colleagues, and they showed an in-hospital mortality for high-risk PE of 28%. Not surprising, right? Not surprising. So the FLAME study was done, and very quickly, I'm just going to mention composite endpoint of 4 things there, including all-cause mortality, some secondary endpoints. The primary endpoint performance goal from this meta-analysis from the literature to hit one of these 4 things was 32%. 32%. Pre-specified interim analysis was planned at 50. These patients were adjudicated by a clinical endpoint committee. And in fact, the study was stopped at about 50 patients based on the data. So this is the FlowTriever arm, large bore embolectomy FlowTriever, 53 patients, context arm, meaning something other than FlowTriever. And the physicians were allowed to choose. It wasn't a randomized trial, kind of like a parallel registry in a way. Physicians could choose what they wanted to do. Lytics in almost 70% of cases. And that's actually higher than most studies suggest. Paul Stein's study showed in high-risk PE, about 30 to 40% of patients get systemic lytics. Either they can't, people are afraid to, et cetera. So this is actually a high proportion getting lytics for a high-risk PE study. So there's the 2 arms, primary endpoint of those 4 things listed at the bottom there. Composite endpoint was hit in 17% in large bore embolectomy with FlowTriever and in almost 64% with context arm. So not a randomized trial. I think intriguing, impressive data. In-hospital mortality much lower with FlowTriever than with the context arm, which was mostly thrombolytics. And while there were more patients with severe shock, D&E shock, in the context arm than there were in the FlowTriever arm, there were no deaths in the shock D&E group, Sky Shock D&E group with FlowTriever, and 43% of patients died if they had D&E shock in the context arm. So interesting study, not a randomized study, but one biggest study in high-risk PE done now with the device. And I think this means that this could affect guidelines. It won't be a 1A recommendation, maybe a 1B or C, we'll see. Safety outcomes were quite good. I'll just say, as is usually the case with high-risk PE, the head bleed rate is higher. And it was in this study as well. In the meta-analysis, it was 3.6%, higher than the usual 2%. So we did an opinion statement, again, 25 years ago, a couple opinion statements. Myself and some of my colleagues listed in red at the bottom there. The ones listed in red have passed away. The others are still with us. I was a pretty junior attending there in 96. And we did this opinion statement because we didn't have good guidelines. We had this study from Mexico City in 1995. 8 patients with lytics. We said, should thrombolytic therapy, open embolectomy, catheter embolectomy, or catheter tip fragmentation be administered in patients with high risk or massive PE? And I would rather hear what a group of experts say about something that have had experience doing it than I would hearing a guideline that's looking for level 1A evidence when it's not available. We said yes, but there's disagreement on the best interventional approach. IV lytics is the most extensively studied. The selection depends on the experience of the physician and availability of the procedure. And I still believe this to this day. If you've got experience, and there's centers around the country that have a lot of experience with modes other than IV thrombolytics now. Filters, I think in the interest of time, I'm going to skip over. We can talk about it if you like. I was going to talk for a minute about factor 11 inhibition. It's been studied now for total knee and hip replacement. I think I'll skip this too in the interest of time, but there's abelacimab, osacimab. Some of these studies, these drugs have been studied. And interestingly, just a quick point about this is if you have congenital factor 11 deficiency, you don't clot as much as normal people do. You clot less, but you don't bleed. It's the fascinating thing about factor 11. So, interesting. We'll see what happens. I think the DOACs really work pretty well, Apixaban, rivaroxaban, but maybe we'll have something that maybe is a better anticoagulant. We'll see. I'm going to finish here so we got time for some comments or questions. Diagnosis of P is often missed. Anticoagulation should be initiated as soon as practical, meaning bleed risk low, suspicion high, even consider starting it before you have a diagnosis. Treat high-risk P aggressively. In catastrophic P, if you can't move the patient, it's ECMO or systemic lysis. If you can move the patient, I think there's plenty of data now, good data with large bore embolectomy now FlowTriever in these stable high-risk patients, and some patients that are Hail Marys. They can't get lytics, have been taken to the cath lab and treated successfully. Those are tougher cases. Lytics should be avoided if possible. If you need them, you got to use them. Intermediate risk PE has a higher mortality than low risk PE. A number of factors associated with increased mortality. Intermediate risk PE, like we talked about. Strongly consider therapy beyond anticoagulation for these patients. Talk about them. Get your PE response team together. Discuss them. I think there's more data coming. Peerless is coming. Other studies coming. High Pythos study. Catheter-directed lysis versus anticoagulation is coming. Peerless 2, FlowTriever versus anticoagulation is coming. A lot of new studies. Aki Sista's PE track study, which is devices, catheter-directed lysis or embolectomy versus anticoagulation alone. More studies coming. But I think we have enough data now to look at these intermediate risk patients and strongly consider being aggressive. So I've mentioned these things already. I'm going to skip through this. I'm going to say we can't solve this problem as individual clinicians. I think this is one disease that takes a team. MI goes to cardiology. Stroke goes to neuro and IR. PE, I think, needs to go to pulmonary critical care, interventional cardiology or interventional radiology. In some centers, vascular surgery teams do PE procedures. Get cardiac anesthesia and ECMO teams involved when you need them. Pharmacy can be helpful. So bottom line is hematology, get these people involved, get these consultants involved, get a PERT team together, and it's teamwork. Teamwork will solve the problem, and I'm going to finish there. So thank you, folks. I hope that came through okay. I've got as much time as you do for comments or questions. So let me stop sharing here. I can go back to the slides if you like. I hope I didn't go through that too fast, but I got a little worried. I know you guys have a lot of work to do. So
no, that was very excellent. Thank you so very much, Dr. Tapson. Comprehensive, and that was brilliant. Thank you as always. So I see a few questions in the chat box there, but before that, I'm gonna ask you a few of my own that came to my mind during your talk. So first and foremost, I was going to ask you actually a simple question. Do you guys use Lovenox or IV heparin for your PE patients? Because I know you said, we need to have the heparin has such a broad therapeutic window, and by the time we get to APTTs, they've probably been subtherapeutic for the last 4 hours. So what do you guys do?
Yeah, so Mass General did a study showing that the majority of their patients are not therapeutic on heparin at 24 hours. We use enoxaparin, 1 mg per kg, Q12, and I like to get once someone gets a dose in, you've done your job with anticoagulation. If you go on to do a procedure, sure, check the AC, use heparin boluses if you need it. But I think starting off, it's great to get some, because then your job is done. In 3 or 4 hours, they're therapeutic. DOACs are the same way for smaller emboli. I think when you need heparin, if you got a high bleed risk, use heparin. You can stop it, obviously, reverse it with protamine. But if you don't have a high bleed risk, I like the idea of enoxaparin, Asma.
Okay, excellent. Very good. And then I have another question, and it probably, you don't have to be exact in terms of numbers, but I do want to ask you, let's say in the last 3 years, how much TPA have you used at Cedars, either as IV TPA bolus or as, in the form of catheter-directed lysis?
Well, much less now, and we tend to go to ECMO more than lytics. We went through a period of time where we argued about it in these catastrophic P cases. They're dying in front of you, and our ECMO team is very fast now. I like the idea of ECMO. If the bleed risk is low, and a younger patient, we may pull the trigger and do lytics. Depending on the ECMO team, et cetera. The first patient I ever saw that had head bleed, had a compound thrombophilia. She was 25 years old, and I told her parents, we need to do this, and she bled in her head. So we've needed them for a long time. I think we're moving away, and we're using them much less than we used to. Now for intermediate high-risk P, we can get someone to the cath lab for catheter embolectomy, we do that.
Okay. All right, great. I just got one more. So with the flame, with the flame under our wings, so to say, what do you think, how soon do you think would the American College of Chest Physicians adapt this in their guidelines? Because it seems like that's the main bottleneck, because,
Sure.
And they're also bound by what the data they have, or the guidelines so-called they have. So that seems to be a recurrent theme, even in some massive PEs, but definitely in massive PEs. So how do we, are you guys doing something, lobbying, to get that in the guidelines?
Yeah. I'm hoping the team will look at that carefully, because again, I think the guideline right now for high-risk P for lytics is a weak guideline. It's a weak guideline, which means you can kind of do what you want. But I think what this may do, Asma, I think based on the fact it's not a randomized trial, it's a large large trial for high-risk PE. If they call it a large trial, level 1 or class 1 means recommendation. Level A means multiple randomized trials. Right now, it's a 1B for lytics. I'd say because there's at least one randomized or one non-randomized trial that's big, it should be a 1B. But they may say, no, it's not a big study, it's a small study, so it's going to be a 1C. I think it should be a 1C, at least. I don't see how you cannot give a level 1 recommendation when you have a much larger study than we have. And again, the Python study, biggest lytic study, 1,000 patients, showed you decreased deterioration, but the head bleeds were unacceptable. So we'll have to see what happens, Asma. But I hope that there's got to be a discussion about large bore embolectomy flow retriever now, I think, in guidelines. I think it's got to be discussed, at least.
Absolutely. Absolutely. Great. Excellent. So now I'm going to refer to some of the questions in the chat box.
Sure.
So I'll start with Dr. Lateeb's question. So Dr. Lateeb, is the director of our interventional cardiology program and the director of head of our structural intervention. So he's asking, this is a very important question. What do you think is the reason for such a low referral for, large bore thrombectomies in your mind? Is it awareness? Is it education? Or is it just what we basically talked about, lack of randomized data?
I think it's all three, Asma. I think Azim asked a very good question. I think part of it is some people are just hung up on God. They want level 1 data. And again, if you wait for level 1 data, we have to practice medicine, the art of medicine. There's many things we do in pulmonary critical care that we don't have guidelines for. We do. I've bronchoscoped thousands of people that probably, when I did the bronchoscopy, there probably was not a guideline recommending I do a bronch in that setting. For example, I think part of it is people waiting too long. Part of it's education. I was in Grand Rapids, Michigan. They have a great PERT team, pulmonary and interventional work together. They do hundreds of catheterectomy embolectomies per year. They rarely use lytics except when they absolutely have to. So I think part of it is lack of experience, lack of awareness. I think if my pulmonary colleagues would go to the cath lab and watch an interventionalist do one of these procedures, they'd be kind of blown away by how fast you get relief. Does it always work in every case? Not always, but more often than not, it does. And it's a very, very safe procedure in a good interventionalist hands. So I think getting the word out, getting more data will certainly help. But I think, again, just like with Clot in transit, AHA said observational data is good enough. You don't even need a randomized trial to do an aggressive procedure for Clot in transit. So I think the same thing is true for high-risk PE. I don't think we need any more data, but the more data we get, the happier people will be.
Absolutely. Absolutely. All right. So I have another few questions. So the fellows are asking, so if you have baseline RV dysfunction or dilatation, then in the setting of a new PE, what other parameters would you look for to risk stratify them?
Great question. And there's more we could talk about to the fellows here about this. What I would say is sometimes you have baseline RV dysfunction from your COPD or for something else. If you think it's due to PE and the clot burden's extensive, you've got at least a saddle embolus, main pay involvement, lobar involvement. I think, to me, RV dysfunction is enough. Tachycardia really pushes me, but sometimes patients are on DILT or beta blockers. You got to really be careful. Katie Hoff, Olympic swimmer, was seen for 2 months for her PE before anyone realized it was a PE. Her heart rate was 60, and they said it's not a PE. Her baseline heart rate's 40. So again, I think you got to look at a number of the parameters I talked about. I look at heart rate, but really look at clot burden and RV size and function. If the RV-LV ratio is greater than 1, odds ratio for death from PE is 5. For RV-LV greater than 1. A lot more data we can talk about. Look at the patient, look at clot burden, have a discussion about them. And again, if you got interventionalists, I think strongly consider procedure nowadays. I think that's where we're headed.
Excellent. So I think you talked about this. My next question basically is a segue to what you already spoke to. Is basically, you said already that if the heart rate is low, either from beta blockade or because of excellent athletic conditioning, then you basically look at the patient as a whole and other risk factors to stratify. So, then another question from Japan. So do you do a CT scan to check for DVT? I guess, do you scan for a DVT at the same time? Dr. Kono says that in Japan, we always check CT to check the burden of DVT, and the burden of DVT changes your management. Does the burden of DVT change your management, such as catheter thrombectomy for PE versus thrombolysis, or or endovascular treatment of DVT as well?
Yeah, and thank you, Toshiki Kuno, Japan, for asking that question. We did the PIAPEDS 2 study years ago, myself, Paul Stein, others, and we found that by doing a CT and including the legs, we often didn't make a difference in intervention. But back then, we weren't doing interventions like we are now. We didn't have the capability. I like that idea. I think Japan may be ahead of the game there. If you can do it without a lot of extra contrast and save yourself a trouble, CT of the legs is off very accurate, sometimes better. You get a better look at the iliofemorals, the IVC. I really like that idea. Now, again, we don't have a guideline saying do something different. Maybe that's coming. We had a patient not long ago, came in with big PE, was treated aggressively, and then the next day still had extensive common femoral vein and down clot in the leg, and that was treated with a clot treater device, another extraction device for DVT, very successfully. And I think we've shown in the Clot study, 500 patients reduced risk of long-term post-thrombotic syndrome with being aggressive in these cases. So Toshika, I like this idea. I think we should expand on it and consider being more aggressive in patients that have significant residual DVT. We don't have data for FEMPOP DVT. Should be aggressive with those. But above FEMPOP, common femoral vein, iliofemoral vein, I think consideration of those cases makes sense.
Okay. All right. Very excellent. I do not see any more questions, but that was a fantastic talk. Thank you very much for giving us your time, Dr. Tapson. Thanks a lot.
Great to see you, Asma. Great to see you folks out there. My email address, I think, was on my last slide. If it's not, it's very quickly, victapson@gmail.com. I have several other email addresses from Cedars or Inari, but feel free to email me if you want to chat sometime. Thanks, Asma. Have a great day, folks.
Thanks a lot. Thank you, everybody. Bye. Have a great day.
Bye.